So here are some important facts about testing in C. diff cases. First of all, current tests for C. diff are accurate, so this means there's no need for repeat testing, and tests for cure should be discouraged. Second of all, as many as 7 to 21% of hospitalized patients can be colonized with C. diff. And that's why it's important that testing is only performed on unformed diarrheal specimens. And last but not least, if we do get a positive diarrheal stool sample back, we should automatically send it to the Infection Prevention and Control Team, the IPC, and the entire care team as well. We can treat C. diff with the help of antibiotics, as well as fecal transplants, which are used for severe and recurrent cases of CDI. And since the immune response plays such an important role, especially in the recurrence of C. diff cases, immunotherapy has been used in recurrent CDI. On top of that, the use of probiotics, such as the Lactobacillus species, should be considered in the treatment of C. diff. According to Goldenberg et al., there is moderate quality evidence suggesting that probiotics are safe and effective in preventing CDI. So this is where it gets a little bit tricky. Which antibiotics should we give to our C. diff patients? So first of all, there's Flagyl PO. This has not been approved by the FDA for C. diff use, but it has been shown to be effective in mild to moderate infections. The dosage for Flagyl is 250 to 500 milligrams 3 to 4 times a day for 10 to 14 days, and some of the side effects are dizziness, headache, abdominal pain, anorexia, nausea, or leukopenia. Next, there's vancomycin PO for more severe and recurrent cases of C. diff. The dosage is 125 milligrams every 6 hours for 10 days. The side effects include ototoxicity, nephrotoxicity, nausea, vomiting, hypotension, and leukopenia. And last but not least, with Difficile PO, the recurrence rate may be lower than with vancomycin, but it is more expensive than Flagyl or vancomycin. The dosage is 200 milligrams twice a day for 10 days, and some of the side effects include nausea, abdominal pain, and anemia.
Aside from the physiological stressors of CDI, there are psychosocial stressors as well. In a qualitative study, 9 patients were approached. The patients had a history of recurrent CDI who visited a clinic in Toronto, Canada. Qualitative data was extracted from the patients' comments and answers to the survey given. Questions were closed and open-ended, intended to reflect various determinants of health like health literacy, personal practices, and coping skills. The participants ranged from 40 to 90 years old, 5 male, 4 female. 5 of the participants had experienced more than 4 episodes of CDI. One main stressor for CDI patients is knowledge and understanding CDI. Many patients wrote about the confusion and uncertainty they had faced. They often had comorbidities, and the medications that they took had side effects, making it more difficult for the patients to understand what was causing their symptoms. Infection control. Patients worried about passing the infection onto others and wanted to know how to prevent transmission. Lastly, education medium. Many favored verbal and written education about CDI. Some received it and some did not. A lack of patient knowledge and understanding contributed negatively to their experience. Recurrent CDI patients were unsettled when they did not know what to expect from their infection. They wanted to understand their symptoms and know when to seek medical help. These feelings were expressed even after receiving regular verbal education on CDI at the clinic. Now for some interventions. There are 3 recommended interventions for these patients who feel confused and uncertain with understanding Clostridium difficile infection. First intervention is providing written educational materials describing the symptoms of CDI, some contact information for care providers, and guidance on how to react to specific types of symptoms. Secondly, ongoing patient education is important on the infection prevention and control aspects for CDI, both to address the excessive and unwarranted anxiety that some of these patients feel about spreading infection, and to reinforce awareness of the risks and mechanism of disease. And last intervention, As emerging therapies for CDI become more available, reliable information and guidance on how to access them would help to alleviate this area of patient frustration.
Antibiotic stewardship is of critical importance because of the role that antibiotic overuse and misuse plays in the development of C. diff infection. We should pay particular attention to patients who may be at risk and question the appropriateness of antibiotics when necessary. Special attention should be given to Levaquin, Cipro, and clindamycin. A study published in 2017 examined the effect of antibiotic stewardship on the incidence of infection and colonization with C. diff infection. The researchers of this study found that antibiotic stewardship reduced the incidence of C. diff infection by 32%. C. diff formed spores, which poses a unique challenge for hand hygiene practices since the spores are resistant to the bactericidal effects of alcohol and most hospital disinfectants. Current evidence on the effect of hand hygiene practices in infection prevention is reported as being moderate quality due to the lack of healthcare workers' compliance with hand-washing practice. Recently, a study found that compliance with WHO recommended hand-washing by healthcare workers caring for patients with C. diff was observed to be approximately 60 to 70%, with no hand hygiene conducted inside isolation rooms. There was a much higher compliance observed for both gloves and gown use. Current evidence shows that hand-washing, in accordance to the WHO recommendations, combined with proper glove use, is an effective measure in preventing C. diff transmission. With that being said, remember to wash your hands with soap and water before entering and leaving an isolation room, and to dispose your gloves appropriately. Contact precautions are an important measure in the prevention of C. diff transmission. Current research states that contact precautions should be maintained for at least 48 hours after diarrhea has resolved, with a possible extension through hospitalization if the hospital's C. diff rates are elevated despite proper infection prevention measures. In 2018, Cottage Hospital had a CDI rate of 9.4 per 10,000 patient days, an infection rate greater than the national mean by 1.31. Beginning this year, Cottage Hospital implemented a new screening tool during the admission process to detect for community-acquired C. diff, with an aim to lower their infection rates. The screening tool is nurse-driven and consists of 5 questions that determine if a stool specimen should be collected for further testing. The first question is the most crucial and asks if the patient has had greater than 3 unformed liquid stools in the past 24 hours. If the answer is yes, the remaining questions will be asked. Next, is the patient taking anything to promote diarrhea? Is the patient over the age of 12 months? Does the patient have history of other conditions that cause diarrhea? And is the patient being treated for C. diff at this time? If the patient is over the age of 1 year and the answer to the other questions is no, a stool specimen will be collected and tested for C. diff. Question 1. A patient tells you they once took an antibiotic that caused them to have C. diff. The patient is unable to recall the name of this antibiotic. In the patient's med history, you see the antibiotics listed. Which antibiotic is most likely to have given the patient C. diff? A. Clindamycin, B. Bactrim, C. Azithromycin, or D. Flagyl? The answer is A. Clindamycin. Fluoroquinolones, penicillins, clindamycin, and cephalosporins show the highest incidence of causing C. diff infection. Question 2. C. diff bacteria can cause swelling and irritation of the large intestine or colon. This inflammation, known as colitis, can cause which of the following symptoms? Select all that apply. A. Diarrhea, B. Fever, C. Weight gain, D. Abdominal cramps, or D. Hearing loss. A. Diarrhea, B. Fever, and D. Abdominal cramps are correct. Clinical manifestations of C. diff include diarrhea, fever, anorexia, nausea, and abdominal pain. Weight loss rather than weight gain is associated with C. diff. Hearing loss is not associated with C. diff at all. Question 3. Which of the following is not recommended in the workup of suspected C. diff infection? A. White blood cell count, B. Serum creatinine measurement, C. Stool testing in asymptomatic patients, or D. Polymerase chain reaction PCR assay? The answer is C. C. diff testing is not recommended in asymptomatic patients, owing to the difficulty in distinguishing asymptomatic carriage from infection in this setting.